Are we ready? Yeah.
Yes, please, Chair. Yeah.
So just to welcome everybody to today's Health and Social Care Services Subcommittee, and we will just start off with any apologies.
Chair, we have apologies from Councillor Stephen McCann. Councillor Shirley.
Did I lose your volume there? I think.
I'll repeat it if I need, Chair. So Councillor Hawkes and Councillor McCann.
And Anne-Marie Fitzgerald as well. Okay. And I know Colette was trying to get, I'm not sure if she's in yet, but she's definitely trying to get in. So we'll sign the minutes of the previous meeting held on the 7th of September. So I'll do that. So next is any declarations of interest. And nobody's indicating there. So we will go to matters arising from the last meeting. And we'll go through each page. Page 1. Page 2. Page 3. Page 4. 5. 6. 7. 8. 9. And 10. So can we have a proposer for those minutes, please?
Sorry, Chair, we're okay. They've been adopted, so we were
right.
We don't
Okay,
need
so
any further.
we're all right. We don't need to do that. That's good. So we will go on to the next item then, which is item 5. And we are going to receive updates from the Trust on the following: winter planning, OMA and Southwest regarding recruitment and palliative care across the district. So I'm not sure who I'm handing over to for that. Chris, that's it. Good.
Hey, Debbie and everyone else.
Fine.
Yeah, so I know Neil's here with us as well, isn't he?
Yeah.
I suppose I would like to take you through our winter plan, just if that's okay. I'm not sure if Neil wants to do any opening remarks or anything, or we just continue.
There's
Happy
nobody
enough?
indicating to come in there. Yes, so we're happy enough if you carry on. That's lovely. Thank you, Geraldine.
Okay, so can we go to the first slide, Chris, please? Okay, so this is the winter plan for the Western Health and Social Care Trust, and the plan, I suppose you would acknowledge at this stage, is based around 3 regional high impact areas and 3 things that you won't be surprised about. First of all, maximising ambulance capacity and ensuring, I suppose, for ourselves that we don't hold up ambulances at trust facilities when we don't need to. We want to reduce time spent by patients in our emergency departments that are awaiting clinical decisions and next stage of care. And you'll all be aware that under the pressure at this minute in time are emergency departments with high volumes of patients waiting admission to beds. And the third key for us action is around timely hospital discharge for patients who are medically fit for discharge. And we all know the reasons why sometimes they cannot move on. However, it's really about the help that we need as a trust to make sure patients are discharged in a timely manner, and that the public understand how important it is for us to ask them to take their loved ones home as quickly as they can when they are medically fit. So there's also some key enablers that will help us deliver this across the healthcare system, and one of the key enablers I would hope that you would support us on is around the health and well-being of our staff throughout the winter period, and obviously then our preparations for surge, etc. So this slide really sets out the entire plan for us. and I suppose it consolidates the work that we've been doing to date. So in terms of maximising ambulance capacity, we have been working with our colleagues at the Northern Ireland Ambulance Service to make sure that we turn around ambulances to allow them to move on to the next pickup as quickly as possible. We have enhanced coordination and patient transfer support in place. We have, as you all know, enhanced our ambulatory pathways at Altnagalvin and to a certain extent South West Acute Hospital, and we intend to enhance that pathway even more. We are awaiting some funding and investment around same-day emergency care at South West Acute Hospital, and actually more effective pathways in terms of integrated community pathways for patients, particularly elderly patients in care homes, and then the access to frailty clinics. So there's a lot of work going on in terms of turning around our ambulances and making sure they're available for the next pickup. We are the best in the region in terms of ambulance turnaround, and it's really important that you know that, and we do not hold ambulances up any longer than we need to. However, we had a bit of a dip at Altnagalvin in October in terms of the turnaround time. We exceeded the 60-minute time on more occasions than we would want to, but the reason for that was we had part of our capacity closed over a 6-day period whilst we did some work within the department. Although we had contingency arrangements in place, we still had a bit of an impact on the ambulance service. So really high important target for us is to ensure that doesn't happen. For patients then, reducing time spent in our emergency department. So again, we're doing some work around a minor injuries unit at Altnagalvin Hospital and splitting it off, or we hope to split it off from our main emergency department to create capacity within the department for the sicker patients that require full emergency support. We have now got our coordination hubs up and running. We have a very robust coordination system in South West Acute Hospital, and in the past week we have commenced our hub at Altnagalvin with information coming centrally from South West Acute, and a really dedicated resource, a really brilliant resource in South West Acute in terms of patient flow and creating improvements there. There's work ongoing with the mental health liaison team in terms of support for patients in our emergency department. And we also have a very robust ED staffing stabilisation plan, which is now coming to, I suppose, fruition in terms of new recruits, our new nurses coming out, and we are really pleased with the progress on that across our both sites. In terms of timely hospital discharge, we have a very robust coordinated approach to patient discharge. We have been, over the last number of weeks, identifying patients the day prior to discharge, those that potentially are golden patients going into the next morning, to make sure they're ready for discharge early in the day. So they transfer to our discharge line, so the activity within there is increasing. We have enhanced independent sector care home or oversight arrangements, access to intermediate care beds and EMI placements, enhancement coming on stream later on in the year. And we have, I suppose, committed to maximising domiciliary care provision. Our AHP focus at this minute in time is on supporting discharge and hospital flow. In terms of all of that, and in addition to all of that, we must also protect elective capacity, because sometimes our on-schedule flow takes priority, and so it should. However, we have patients waiting a long time for their surgery, and over the winter period, there's a real focus on making sure that we deliver in terms of our targets and recovery plans for patients sitting on those waiting lists across a number of specialties. We also have agreed to explore hospital capacity and capability to maintain those services to make sure that we don't have to stand down any elective activity. You'll hear from Mark later about maximising the theatre capacity, building on our dedicated elective daycare and overnight stay models at Omagh and Southwest Acute Hospital really, really high priority for us throughout the winter. And obviously then continuing to make sure that patients have equity of access to elective capacity throughout this period of time. Key enablers to allow us to do that will be the support in terms of protecting staff health and well-being. We have targeted sickness absence support within our occupational health department. This is all about keeping people at work and keeping them well and supported. In terms of senior management visibility out and about, so that we make sure staff feel valued and obviously get our support when they need it most. A vaccination program that makes sure that we are prepared for any surge that may happen in terms of the implementation of COVID booster and our flu vaccine as well. And I suppose we reviewed all our business continuity arrangements so that we are in a position to ensure that services are delivered irrespective of that. We know and we expect probably to have more industrial action, and there's a lot of work going around that in terms of communication with our staff, public and key stakeholders around that. And then just monitoring and reporting all of the above, making sure that people know exactly where we're at with our plans, making sure that we have oversight at all levels across all service areas, and I suppose escalation plans when we need them, both internally ourselves and externally with the region. And we have had a number of those tested in the last weeks with our Encompass go live in terms of escalation at South Eastern Trust. And we know that there is a regional coordination centre coming on board to oversee all of the trust work in terms of winter planning and how we flow our patients on a daily basis. And again, we tested that out last week when South Eastern Trust went live with Encompass. So there's a lot of information there. It's there for you to go through at your leisure, but there's a few things I just want to say how you can support us. There are other options to our emergency departments. You know, we have local pharmacies, we have our GP service, we have minor injuries unit, we have other options for patients. And I suppose I would ask that when you're talking to your constituents, etc., that you promote those real key enablers for us over the winter, and we will be doing that ourselves in terms of informing the public as we go forward. Thank you.
Thank you, Jo. I can't see anybody indicating to speak, so I'm not sure if you can, Alison, or is just something else?
No, Councillor Roof has just put up his hand, Chair. So.
Oh yes, so he has, yeah.
Thanks, Chair. It's just a quick question regarding the ambulance waiting target being missed. You mentioned it was due to work ongoing, like an upgrader on site. Would that target have been reached without the ongoing work, or was it also due to pressures? Thank you.
We monitor this very closely. It was the only point across the entire year we went over 60 minutes for a long period of time, and the key factor in that was that we were doing work in one of our areas within the emergency departments themselves. So we prioritize ambulance turnaround. We focus every day on it, every hour of every day. So yes, we were down cubicle capacity, we were down 10 chair capacity. So I do believe that this impacted on our ability at that time over those days to do our normal business in terms of turning it around.
Thank you. And can I just ask Geraldine, please, the GPs, you know, there's most people that I see, and it doesn't matter what you say to them, some of them haven't seen their GPs for months or even a couple of years, and it's starting to kind of cause a problem for people on benefits the likes of DLA or PIP, because they can actually use that against them. But that wasn't the question I was going to ask. The thing is, that a lot of them GPs actually do send their patients to the likes of A&E, sorry. So is there a bit of work that yous are doing with GPs to try and, you know, prevent them from sending people up to A&E, especially on a Monday, because that tends to be the busiest day? And also I was just going to ask if there was any chance of us getting a copy of this presentation.
You can certainly have a copy of the presentation. There's no question about that at all.
Lovely, thank you.
Debbie, but in terms, so we have worked with our GPs. We have worked with very closely with the local GPs across the entire Western Trust geography in terms of setting up our ambulatory care pathways, what would help them to make sure their patients are seen. Our GPs have direct access into our ambulatory care services. They can, you know, ring up there for advice. They can send the patient there that they have in front of them, make that appointment today, get in there. They don't always have to send the patient to ED. So I suppose when they make a decision to send a patient to our emergency department, it's either based on the difficulty of that patient, they can't deal with it, and it is a true emergency, etc. And you will always get that, Debbie, always. Yeah. So, I mean, we see every patient that comes in without fail. So, I mean, I can't comment on the pressures the GPs are under, but we have worked with them. We have put in place a number of pathways that they can utilize to get their patients seen and to get support. And the other piece for me is that we are hoping to expand that now over the next number of months with the same day emergency care piece at Southwest Acute, just to make that even more robust than it has been up until now. So looking forward to doing that.
Yeah, that's great, thank you. And just lastly then, on some of some people aren't aware that pharmacists are so helpful, and I've seen in the town some new kind of posters to encourage people to go to the pharmacist, because they are so helpful, and you know, they're very good at helping. I would rather go there than sit in any GP surgery or ED, you know, for hours. So sometimes they are, you know, they are what you need. So there, you know, is there a good promotion now coming into the winter to try and encourage people to go and see their local pharmacist and try, in the first instance anyway, to maybe get some help there?
Yeah, and I suppose we could share with you, we have a wee poster about how you help us play our part in the health services around what other options are available to the members of the public. And in terms of your local pharmacist, it's right up there, you know, at the top, and they're there to give you confidential expert advice, can treat a number of minor ailments, and you all know all of this anyway. So yeah, we'll be promoting this out and about now in the next number of weeks.
Very good.
Chair, Councillor
Thank you.
Ovens.
I can see that. Mark, do you want to come in?
Okay, thank you, Chair, and thank you very much, Geraldine. I suppose from the outset, I should say I wish you well, and I mean, I wish all your colleagues well in the Trust as we move into a pretty difficult period. I mean, I know winter pressures aren't unique, and the same winter pressures that were in place last year will be equally in place again this year, but I appreciate that this is a very difficult and very challenging time for any trust. It's not a problem unique to Northern Ireland or to the Western Trust, but it's just the point to reiterate that I don't, and I know many others on the call wouldn't underestimate the level of challenges that the Trust are already experiencing, but about to experience to even greater levels. But in terms of, Geraldine, there's a point that you had made during your presentation about the priority is to protect elective services wherever possible, and that's something that very much welcome and support. But whenever I was having a quick look, just in terms of the Trust, the Western Trust's most recent activity levels, I see the outpatient activity levels, for instance. I mean, the target's 105% compared or measured against the old 2019-20 pre-COVID baseline, but I see the Trust are still at, was it 91%? And this must be too. And even setting aside disruption due to our industrial action, the Trust would have still fallen significantly below that target. And then equally, it's worse actually for inpatients. I mean, the target is 100% compared to pre-COVID baseline, but the Trust fell in at, I think it was 83%. I made a note of here. So it's just really how whilst I appreciate going into winter, it's very difficult to predict. But I suppose the question would be, I mean, how confident are you that the trust are going to be able to maintain the levels of elective activity as far as possible, and ideally continue to improve the levels of elective activity? Because conscious that, you know, if the trusts are still only at 23 or 83% of pre-COVID patient activity, I mean, it's like everything else is going through there. So ultimately,
Okay, so sorry,
Yeah.
Mark. Sorry, were you finished? I didn't mean to.
yeah. No, it was just a question, Geraldine, just about how the trust would try to protect them, not just protect it, but also
So
grow
from
it.
my perspective, in terms of the on-schedule care flow, and I'll come to Mark in a minute, and he'll obviously have his own confidence level in terms of delivering the planned care piece of it. What I don't want to do, I don't want to be going to my colleague director or the chief executive to say, I need, you know, I don't have enough beds for these patients. I need you to make a decision about cancelling elective. So what we have done in this plan is try and support flow from a senior level, which is the coordination hubs. So it's myself and assistant directors who are managing that on a daily basis to make sure, you know, patients go to the right place, etc., and good decisions are made. I don't want to use the beds that we would normally use for elective patients for that reason, because they are waiting long enough. So the issue for me is about making sure patients are admitted timely and discharged timely, and discharge is a real issue for us, and we need to get some information out to the public about making sure we get early in the day discharge to allow that flow to happen for us. But in terms of confidence around our outpatients and our inpatient activity, Mark, do you want to comment?
I was going to say, Jodie, I'd probably cover some of that in the presentation.
Okay.
I suggest, Mark, maybe Mark Ovens, maybe if Mark Gillespie can give his presentation, and I'm sure if there's any residual queries you have at the end of that, Councillor Ovens, we can pick them up after that. So I think some of your question will be answered directly by the presentation, and maybe Mark can answer some of it in his narrative as well. Sure, hopefully. Is that a reasonable, Chair? Is that a reasonable approach?
Yeah, that's perfect. Yeah. So we're going on to that now, aren't we? Yeah.
Well, can I be very rude and just say I joined the meeting a little bit late, Chair, and I'm very conscious I'm having to go at 4 because of another pressing engagement. I just wanted to give a couple of comments before I pass over to Mark, if that would be okay.
Yeah, that's no problem.
Just following on from some of Geraldine's comments, I think it's very important that we emphasise that staff retention and protection is absolutely vital at this stage during this winter, and indeed right into the next number of years. I do really welcome, and I want to place on record, you know, how much I welcome the fact that we are working together as partner organisations, and I think it's extremely important going forward. I do also want to commend the fact that the Chair of Council held a reception for junior doctors in your grounds and in your facility, and I really welcome that. And I also feel that the valuing our staff and recognising our staff is really important at this difficult time. There are a lot of reasons why staff in health and social care would feel, indeed in any public servants at the moment, would feel undervalued. But I would really welcome further discussions with Council to see how we can work together to particularly value health and social care staff as the role they play in the local community and the role they play in our facilities and our services. I do note that today the terms of reference and the notes of our strategic development group are on the agenda, and I won't be here for that discussion. However, one of the many central planks that I feel in terms of our development of South West Acute Hospital into the future is the strategic development group. It's at its early stages, but I think it's really useful having a range of stakeholders on that group, including indeed very senior officials from the Department of Health, because we believe some of the levers to the future development of the hospital will lie outside of the trust, and we think it's really, really useful not just having the local partners like your council and service users and the community reps and indeed staff reps, but it's also really useful to have Department of Health reps there because they will dictate the future for many hospitals in Northern Ireland, and it's really useful that they're in the meeting and they're actually contributing to some of the solutions for the future for South West Acute Hospital. So I think it's worthwhile also to maintain the relationships with them and indeed with all parties. So just wanted to highlight that. Unfortunately, I won't be there for that discussion. So thank you, Chair. Sorry to delay the meeting, but
Not
I'll
at all.
hand over to
No, it's
Mark now.
important to hear that and for you to express that. And in fact, yourselves done an evening out in the Manor House Hotel for the international nurses, which I attended in place of the chair to represent the council. And one of the requests there was that maybe the council organises a tour of Enniskillen and Omagh and nearby, maybe parts of Fermanagh for the internet, because they come here and they know where they live up the road there, and they know how to get to work and they know how to get back, but they don't know anything about the town. So we was asked. So Chair's away at the minute, but I will be chatting to Thomas and seeing if there is something maybe that we could do there for them to make them feel welcome in our towns. So we'll go on to the next item then, item 6.
Okay, thank you, Chair. I just note, Neil, as well too, that Teresa has put some narrative in the chat box there, just in and around outpatients as well too, that might be helpful, just to set context. But I will elaborate a wee bit more as we go towards the back end of the presentation as well too, just in and around theatre rebuild and around regional programmes of work as well too, because there is a lot happening in that space. But just for starters, we had thought that it would be very useful just to outline what the activity in South West Acute particularly, and I'll talk around Omagh as well too as we get to a little bit later on in the presentation, just in terms of the busyness of the actual site and what has been undertaken within the site. I'll also touch a bit more as well too on general surgery, and I'll touch a bit on new appointments to the trust as well too, with particular focus in South West Acute. So really important to note that the emergency department, if we compare data from April to September of last year with data of this year, which is post the temporary change in emergency general surgery, what we see is a really busy emergency department. And indeed, in January and February of this year, the emergency department at SWA was probably the busiest it had been ever. And that's really important from our perspective, given the temporary change, because what we really wanted to instill was good public confidence in that service. We know we have a very stable consultant workforce there, and what we wanted to do was maximise the capacity capability, but also to minimise the impact on individuals in terms of travel. So really important that we can see that that is a thriving emergency department, and we continue to want to see that. Also, from the point of view of admissions, whilst we are not admitting patients with emergency general surgical problems, and we can still see that hospital is being well utilised from an inpatient perspective. Also, consultant outpatients, if we look at them, this will be in excess of 15,000 at this point. So again, busy from an outpatients appointment, but it's not just about consultant outpatients and what consultants deliver. It's also about our AHPs in terms of our physios and our OTs. So again, if we looked at that in total, we would be seeing in excess of 50,000 outpatient contacts at this point as well. Also, we are acutely aware, and we do look at the data on a daily basis within Trust as well to around movement of those surgical patients. And given the fact that we were 9 months into the change in September, we took the opportunity to take stock with our colleagues in the Northern Ireland Ambulance Service and our senior clinicians to review those pathways that we put in place in December of last year. And as a result of that review, we did not decide to make any changes to those pathways. As a senior group with oversight of that activity, we deemed those to be safe and continue to be effective at managing that particular aspect of care. People will remember from our planning assumptions pre the change, we had talked to potentially 4 to 5 patients transferring on a daily basis. We are seeing 2 patients transferring on a daily basis. Obviously, there will be peaks and troughs, but if we're working on averages, it tends to work out in around 2 per day. And I'll talk a bit more about ambulatory care and the developments that we've made in ambulatory care in South West Acute as we go along. Council will also be aware as well too that temporarily rheumatology services weren't available in South West Acute, and really important for the population because they tend to be perhaps frailer patients. That service has recommenced in South West Acute. again, and also in OMA as well. So really important that that service is available to the population. Okay, so obstetrics and gynecology, you will remember from the temporary change, it was one of the areas that caused probably a huge degree of concern publicly. We have been working hard in the background with our HR colleagues, and we are pleased to note that we have got 2 new appointments made to Southwest Acute. However, there is 1 resignation as well too, and that individual will leave the organisation in January of next year. Live births, again, really important that we take cognizance of live births from the point of view of the ED and the ED data as well. We have seen between April and September more live births for that period of this year. Again, really important from our perspective that there is still confidence in that service moving forward, and we will continue to build that infrastructure from the point of view of clinicians as we move forward. People will also remember that when we met with the Obs and Gynae team at the point of time in the temporary change, one of the things that they said was that would be helpful for us to attract people to come and work in Southwest Acute was access to theatre. You will see in the data later on that we were significantly challenged during last year to rebuild our theatre services, and we've got a really good success story to tell there around getting back to full rebuild in Southwest Acute later on this year. So by November of this year, we will be able to provide 5 sessions of inpatient operating for Obs and Gynae in Southwest Acute, and we will also be able to fulfill 5 sessions of Gynae in OMA as well. Colposcopy, which had to be withdrawn from Southwest Acute, will be reinstated in November of this year. So again, really important from the point of view of cancer and cancer pathway that service has been reinstated to Southwest Acute. It has been reinstated due to the skills that one of those new appointments brings back with them to Southwest Acute. So really important for that particular pathway. If I can then just to touch on some of the developments from the point of view of Southwest Acute. Neil reflected on the all-party group earlier on and how important that is to moving things forward. We also have the strategic development group, which harnesses the expertise of not just the trust staff, but also council and the Department of Health as well too. And really what we're looking at is opportunities to grow Southwest Acute as we move forward into the future. And we also have a staff engagement group which feeds into that as well. Just to make the point as well too, that we also have a new cardiology consultant who will commence in Southwest Acute actually this month with specialist expertise and skills in cardiac MRI. And during the last visit of the all-party group, we had the opportunity to meet with Monica Monaghan, who is the lead for cardiology in Southwest Acute, and that will really bolster that service moving forward. Southwest Acute is one of 3 sites in Northern Ireland that provides cardiac MRI for the region. So it's a regional centre for cardiac MRI, so that really supports that service moving forward. We will see an increase in our theatre capacity, and as I said earlier on, we will get back to 19.5 sessions of commissioned theatre operating by December of this year. We've also got a permanent secretary visit to Southwest Acute and in OMA later this month in November, which is really important because, as you will remember as well, the Trust has been awarded 2 high achievement awards, one for the Overnight Elective Stay Centre and one for its work in data analytics in terms of maximising theatre capacity. Increasingly, we are becoming an organisation that is driven by the data and using data to support the direction in terms of how we need to develop our services. But not just develop our services, make sure that we maximise every inch of our theatre capacity on a daily basis. And we now have the ability to see prospectively and retrospectively what our theatre utilisation will be. So really important that we maximise that given the waiting times for patients. I've already talked about the High Achievement Award, and I've already talked about the 19.5 commission services, and I've also already talked about the new cardiology consultant. We are also now starting to think about the new surgical appointments, which are due to commence work in the Trust next year, where we actually put our surgery in terms of what surgery goes where. So we're actively looking at that with the clinical teams at this present moment in time, obviously with the emphasis on trust-wide working. We're also working with Neil, who is the chair of Project Board, and re-energising that to refresh the options for future delivery of general surgery model on a trust-wide basis. So rebuild trajectory then, really important, folks. People will remember that last year we struggled to deliver 1 or 2 sessions of elective operating within Southwest Acute. Our sessions for the same period last year versus this year, we are up by over 60 sessions based on the same period last year. Really important that has taken us to a different place from the point of view of elective procedures. And SWA, as I said, is funded for 19.5 weekly sessions. 10 of those are inpatient operating, 9 are day case, and 0.5 is MRI. Coming into 23, we only had capacity to run 2 sessions per week, which was used for red flag general surgery or gynae patients. As of September 2023, the Western Trust is in a position to deliver 12 sessions per week. But as I said, we will be in a position to come next month to be able to deliver that full 19.5 sessions. We've never ever done breast surgery in Southwest Acute, and in recent times we've been able to undertake 2 breast sessions fortnightly, providing a new service to the southern sector. We are at full operating for gynae, inpatient operating, which we previously hadn't been, so back to those 5 sessions of inpatient operating. And elective general surgery has been significantly enhanced despite the temporary change. Pediatric surgery has resumed, and just to make council aware, pediatric waiting times are probably at the lowest that they've been over the last number of years, and that's largely down to the support and the capacity that's available and has been made available to pediatrics on a regional basis at Southwest Acute Hospital. It is really supporting the region to make inroads into pediatric waiting times, so that's a real positive for the population locally, but also the population of the region. Just to also make you aware as well, elective overnight stay in previous reports in the news and the media, they were talking about a proportion of total operating within Southwest Acute. And as you can see from the data which was done last month, we had over 940 patients who had procedures in Southwest Acute. That will be well in excess of 1,000 procedures at this point, and only a proportion of our elective inpatient operating actually goes towards general surgery. So there is more than just general surgery being undertaken in Southwest Acute. So one of the other important points that I made earlier on was just around elective or around emergency general surgery movement of patients. Our planning assumptions indicated that we would probably have between 4 and 5 patients transferred. Our data tells us that we have 2 patients transferred on a daily basis. We believe that ambulatory care services allows patients to have their care closer to home with surgical assessment by a senior surgical doctor. And within Southwest Acute Hospital, you'll also be aware that we have excellent access to X-ray and radiology services, including CT, MRI, and ultrasound. And Teresa Malloy, myself, fed back to the local commissioning group recently in terms of the GPs. And one of the pieces of feedback from the GPs was that access to ambulatory was very good. They appreciated having access to a senior doctor to discuss that case for same-day appointment or indeed next-day appointments. We believe that is a service that we will continue to grow and maintain services close to home where clinically appropriate for patients and for the population. Just wanted to take a second just to spend a bit of time just on new appointments as well. As I did say earlier on, we have obstetrics and gynae, 2 new consultants who will be joining Southwest Acute, and 2 new middle grade doctors. We also have a cardiology consultant and a staff grade doctor as well, which I already mentioned. We've got a new radiology consultant, a diabetes and endocrine middle grade doctor. We're exploring opportunities with neurology for neurology services within Southwest Acute as well. And we also now have access to a pediatric consultant with specialist skills in cardiology outreaching to Southwest Acute Hospital. Geraldine earlier in her presentation also alluded to new nursing recruits. Our vacancy rate from nursing perspective will drop from 60 to somewhere between 15 and 20. We've also invested in practice educators, which will support those new recruits and indeed the wider nursing fraternity in terms of their development at ward level. We've also got international nursing recruits as well, which have been well publicised. And again, being very focused on alternative routes or alternative roles within healthcare. We've got 1 new ACP start in the emergency department who is was previously a paramedic, and 1 newly qualified advanced nurse practitioner in ED who will be our second in Southwest Acute. I also just wanted to pick up the piece on outpatients as well too, just to say that the Trust has identified a lead in terms of outpatients. There is a regional outpatients piece of work that will be undertaken. That will be a modernisation piece. We'll explore a number of areas. We'll look at regional modernisation, but it will also look at opportunities for direct to test. So meaning that patients don't have to come for an outpatient appointment to decide that they actually require a test, to have to come back then for the result of the test. So we'll be exploring opportunities for direct to test to make sure that outpatient contact is as meaningful as it can be moving forward. That will help us to eliminate some of the waste that we potentially might see in the system. We'll also be focusing there as well too on virtual and opportunities for virtual, as opposed to people having to attend hospital. We will be focusing on 2 areas moving forward, primarily general surgery and gynae services. And I note that Teresa has some detail in terms of the outpatient piece there as well, but it's really important just to emphasise that modernisation piece that the Trust has embarked on as well. Thank you.
Debbie, you must be muted.
Mute.
Sorry. I'm just going back because I've got the members' queries up.
Okay, Councillor Warrington indicating, Chair.
Yeah, Victor, you can come on in.
Thank you for that, Chair. Just interested with the comments there in where where exploring has gone on in the field of neurology. Can you widen that out a wee bit to what basically the exploration is in the neurology field, please?
I think moving forward, there is potential of somebody who may well be in training expressing an interest and coming back to work within the Trust. So that's where we're at, but that will be a period of time away, Councillor Warrington, from where we are. But we are pursuing it.
Yeah, we all know how light on the ground we are, certainly in the Western area on neurologists, and it's something as no doubt Teresa and Geraldine will know that I have a keen interest in this area, and I have certainly been pushing for quite a while to even get a neurology trained nurse, even on a part-time basis, in this area, schwannoma. So certainly we'll be keeping an interesting eye as we move forward. Thank you.
Thank you, Victor. And Mark?
Thank you, Chair. Thank you very much, Mark. I'm looking at a document, Mark. It's an infographic for the Southwest Acute, and you touched upon it on your presentation and your remarks about the activity levels for the elective overnight stay centre. But again, it's a point I made at our previous meeting of this group that we need to be very careful not to, either mistakenly or deliberately mislead the public into thinking something is happening that isn't really happening. Because whenever you talk about the figure, and I mean, if I refer specifically to this infographic, it talks about the 941, which you now say is well over 1,000, 900, and it's under the title Elective Overnight Stay Centre Activity, January 2023, which is when the Elective Overnight Stay Centre was established, to September. So up to the end of that reporting period, there were 941. But my understanding is that includes core activity too. So that's including activity that would have been happening and had been happening and will continue to happen forever and a day within the Southwest Acute. That is separate to the establishment of the Elective Overnight Stay Centre that was announced previously. So it's just, we need to be very, very careful, I think. And I do think, and I appreciate that you're saying, well, the Western Trust are simply following the lead of other trusts because they're all wrapping their figures up together. But we need to be very, very careful to not to wrap the figures up in one another. So, and then secondly, I suppose, so there's just a broad comment on that firstly, Mark, and then just 2 very quick queries would be, previously, I know this time last year, or over this time last year, more than a year ago, there was a commitment that theatre utilisation rates were to be published by site, by hospital site. Has that happened, and are the Southwest Acute's theatre utilisation rates available? And if they're not publicly available, would you have the information to? I mean, I don't know. Perhaps they are on the Trust website. I don't know. And then thirdly, and it's an issue I touched upon in a previous meeting as well, and I think you were broadly receptive to it too, about just the ongoing issue of productivity within theatres, and particularly when it comes to OMA, DPC, about the late starts and early finishes. I know that it's not a problem unique to the Western Trust, but it seems that whenever centres are established like this, that it's just a persistent problem, and that there seems to be a real challenge in getting on top of it. So they would be the three questions: were infographic about, we need to be accurate and genuine about the figures. The second point would be theatre utilisation, and then third would be OMA, late starts and early finishes.
Thanks, Mark. And back to you,
Sorry.
Mark.
No, Councillor Alvin, sorry, I was just writing down what you were asking.
No,
so I
that's
didn't miss-
okay. That's
I didn't
okay.
miss anything out. Yeah, look, you're absolutely right around accounting and in terms of not misleading the public. And I think if you remember back to the reports in the BBC, actually South West Acute and Western Trust actually split out and reported only overnight elective stay, which was those 5 sessions out of the commission 19.5, whereas the other trusts had actually put everything together, which made it look as if South West Acute was potentially under delivering. The department now have said that they will report on all activity moving forward. So that's the direction. And I mean, I directly fed back about how this could potentially mislead the public, but I think your point is well made. But we will take some of that lead from the region as well. In terms of theatre utilisation, South West Acute's utilisation predominantly is in excess of 80%, because we were not predominantly, but we were operating on a number of children. Some of the downtime within theatre to recover children actually for a period of time took longer than what we had anticipated. We now have a new process in place where that will not have any downtime. So I'm anticipating the theatre utilisation within South West Acute will be close to 90%, which is above the runtime and the utilisation rate that were required to deliver from an SDP perspective. So I think from a South West Acute perspective, they will deliver consistently. But I think one of the things that I did make the point earlier on as well, and Neil will be aware of this, that award that we got for data analytics, that now gives us the ability on a daily basis to actually have individual conversations with individual consultants about their utilisation across the system. So that will only strengthen our ability to make sure that we maximise it. We can't have space in theatres unutilised given the waiting times that are there. So there's very close scrutiny from the point of view of the process that we have operationally on a weekly basis, which is 642, led by an assistant director, where consultants plan their lists 6 weeks in advance. So once we look at it retrospectively, we also look at it prospectively to make sure that what surgeons are planning in their lists actually meets the requirements of that list. If I can then just touch on OMA for a second or two, if that's okay.
Yeah.
The trust were previously commissioned for 23 sessions in OMA, and then 2 years ago we got further commission intention for 7 sessions. We had, due to some of the general surgical vacancies, struggled at times to fill all of those sessions. The permanent secretary will join us for a walkthrough of SWA next week and OMA, and next week in OMA will be the first time that we have been at a total of 30 commission sessions within that particular area. If I can just then go back to the data analytics, which is the other part of the question about the late starts and early finishes, we are now in a position through that work to be able to extract a reason code for why lists start late or finish early. So we are very much in the position where we are able to have those individual conversations with consultants and clinical teams about how we prevent those late starts and early finishes and absolutely maximize that. So first priority was to get the sessions on the ground, and then very closely then scrutinize those other aspects that you quite rightly mentioned. And I'm happy to pick that up at further opportunities, because it's something I can assure you is very much at the forefront of our working day, both moving forward and also retrospectively as well, to being able to interrogate that particular information. I can't answer your question just about theatre utilisation being published, but I do know that it is part of the STP now that we are monitored on from the department's perspective, which is not something that historically that we were monitored on. But I'm not sure, Teresa or Oliver, whether there are plans to do that or not.
As far as I'm aware, folks, there's no plans to publish that information on trust sites at this stage, but quite happy to do so if that's what we need to do.
Thanks very much, Oliver. And if I could just interject, it was, and if you give me 2 seconds, I could almost give you the date. It was the 11th of October 2022 is whenever the minister signed off on that site-specific information being published. Just if you're talking to colleagues. And
no, I'm happy to pick that up through the elective care management team. I'm happy to feed that back. I'll feed that back as a point. That's a regional meeting. Councillor.
Okay, that's lovely. Thank you. And there's nobody else indicating. So if we do we have another presentation on palliative care? No, yeah.
Yes, Debbie, it's me. I'm Maura O'Neill. I'm the Interim Director of Community and Older People. Hello, everyone.
Hi.
So we have a paper which we had. Will I go ahead, Debbie?
Yeah, you go ahead. Thank you.
So we have a paper which we've attached in your pack, and I'm going to go through a number of key areas for you as we go into the meeting. So for myself, I was going to cover the specialist palliative care service provision within Fermanagh and Omagh. And as you all know, it's been experiencing some challenges. So the 4 key areas I'm going to touch on is medical recruitment and retention, a bit about the palliative care medical on-call rota, out of hours medical cover, and then finally a little bit of the palliative care contracts. So first of all, I wanted to start off with some good news in terms of our medical recruitment and retention. So first of all, in the Western Trust, you will know that the palliative care service is delivered by our multidisciplinary team, which is made up of our medics, nurses, AHPs, and social workers, or allied health professionals and social workers. And you will know from the conversations we've been having that we've had extensive pressures over the last 18 months in our medical workforce. However, in the last couple of months, in an effort to grow our own consultants, the Trust are delighted to say that we've recently recruited 3 full-time equivalent clinical fellows, and they will undertake a 4-year integrated fellowship training programme in order for them to then progress to consultant level. So for us, we're delighted. It's local appointments, and we always talk about growing our own and having our own local appointments. And the Trust are delighted to have secured these very skilled doctors who will then complete their training as Trust employees. So that's the first part in terms of a success story in our medical recruitment. The second piece then, Alison, in terms of the palliative care medical on-call rota, as a result of reduced consultant medical cover, the Trust has put in place a contract. And again, it's the mitigating actions that we've put in place in terms of supporting and to secure a contract with Supportive Care UK. And that has allowed a specialist palliative care consultant to have an on-call service with us from the UK. And just to give you a little bit of detail, the contract provides consultant level on-call from Monday to Friday from 5 p.m. to 12 midnight and from 7 a.m. to 12 midnight on a Saturday and Sunday and any bank holidays during the contract duration. The contract has been in place since August and will be extended until the end of March 2024. And just in terms of the numbers, the service has received 42 calls to date. And the feedback from the professionals is that the service is working really well. Thirdly, then, in terms of our out-of-hours medical cover for our Omagh Hospital Primary Care Centre in our patient ward, there's currently a contract in place with our Western Urgent Care, and that's to provide out-of-hours, weekend and bank holiday medical cover. We know that the Western Urgent Care at times have experienced difficulties in filling these shifts. However, we've had several meetings with Western Urgent Care and the Trust to try and increase the number of doctors on call. But in terms of, we talked about transparency and openness, Western Trust and Western Urgent Care are reviewing the current contract, and for the period from the 8th of November to the 14th of November, we were able to cover all shifts in both Omagh and Enniskillen. And then finally, in terms of the palliative care contracts, we just want to update you that the Directorate, in terms of community and older people, have in place a contract with Northern Ireland Hospice. Good news today in terms of we've had some media coverage also in relation to Foyle Hospice in terms of their contract in the southern sector. So that's also good news. So there's been an increased service offered in the southern sector with an additional 1 whole-time equivalent specialist nurse. And the contract transfer will enable the Trust now to geographically to centre palliative care services within the Western Trust with one provider, ensuring that we have a high quality of care for our provision right across the Western Trust. And again, Chris and Oliver will tell you that this will be communicated publicly after today as a really positive development for our Trust moving forward. So through the chair, that's kind of an overview in terms of the some of the positive pieces, but still some of the challenges that we continue to have in terms of our specialist palliative care service provision within Fermanagh and Omagh area.
That's great. Thank you very much. And
sorry, Chris has put it in. I think it's really important to say there's a number of briefing papers along with the items today that will be circulated to members afterwards.
yeah, yes, that's great. Thank you. And Eddie's indicating there. Do you want to come in?
Thanks, Chair. Firstly, I just like to say I'm happy to see the plan to train consultants internally has been successful for palliative care. Just for a point, just to kind of see, when we're obviously going to be robbing Peter to pay Paul in a sense, but where have these doctors been recruited from? What sections, what departments? And I might have missed it, but did you say how long that process would take before they're fully qualified as consultants? Thank you.
Okay, so thank you for your question. So it will take 4 years for a fellowship training program, but what we have done is recruited 3 and they're clinical fellows, and that means after the 4 years they will become consultants. So we have 3 positions in place at the moment. We're not able to just give the detail in terms of where exactly they have come from, but to give you the detail that we have 3 clinical fellows who will then train to become consultants. So it is giving us some provision. However, we will continue to work hard to ensure that we continue to build this service.
That's okay. And a really important service as well, very important. I don't think anybody's indicating, and we're going to get information afterwards as well. So if everybody's happy, we'll just move on to item 6. Is that okay? Which is the members' queries.
Okay, I'll take these, Chair, if that's okay. So there's 10 members.
Yeah, no problem. Yeah.
Okay, so the first query is around drugs and regarding the processes in place to monitor the usage and stock and rotation of drugs. So I know that Chris has arranged a meeting with Councillor Roof, so I'll just give you the high level at this stage. In terms of a response, the Trust carries out regular stock checks of all drugs in pharmacy and procure in such a way so as not to hold high levels, especially of high cost drugs. We have key performance indicators for stock losses and monitor against these each month. There's a network of Trust procurement pharmacists across the region who meet weekly to look at stock management and procurement. We usually dispense full packs of drugs to patients. If we have a high cost drug that we have not used or a high cost drug reaching its expiry, the other trust will be contacted in good time to ensure that the drugs are used. So I suppose that's just a summary of where we're at, and I know Chris has arranged to meet with Councillor Rip to discuss further.
Yeah.
That's the first query. Is that okay?
That's okay. I wasn't sure if he was coming in there, but he took his hand.
Sorry, I had left my hand. My hand up, but I just.
That's okay. You carry on, Geraldine.
I'm happy with the process, and I'll be meeting with Chris at a later date. Thank you.
Okay, so query 2 is an update regarding the shortage of social workers in hospital and community settings. So we would like to provide a presentation at the next meeting regarding this. We have some statistical data, but we'll need more of a presentation. And there was just too much for today. Chair, if you're content with that.
Yeah, absolutely. Yeah, no problem.
Yeah. In terms of 3, regarding the update regarding utilisation of local enhanced hospital in Omagh, I think Mark has covered that in his presentation. Unless there's something further specifically that is required, that's okay as well.
Yeah, there's nobody
And
indicating.
there's quite a bit of detail.
That's right. Yeah, and we're getting bits afterwards as well. So nobody's indicating. That's okay.
Thanks.
Gerald.
Okay, number 4, update regarding cancer patient treatment. So at the last meeting, you'll recall that I asked for specific details because cancer is a wide and varied service. And to answer and to give an update on a specific aspect of that, I would need to know the detail. So no councillor has come forward to me with any specific information, Chair, and I suppose my offer still stands. That if any councillor would like some specific information about an aspect of cancer service, I'd be very happy to provide an update. But I in terms of the wide, service in its entirety, it just would be impossible for me to do that. So I'll await that if that's okay.
Yeah, that's fine.
Number 5, clarification as to why residents in rural areas of Fermanagh are being requested to travel to Altnagelvin Hospital for routine appointments. So I suppose again, which specialty is this? Because I'm sure all council members are aware we don't provide all the specialist services at Southwest Acute Hospital that we may do at Altnagelvin. There's a number of specialist medical services, cancer services, etc. And I need to know which service they're referring to. Also, is it a specific patient that was asked to travel for something? Maybe just the appointment was available there. I don't have enough detail to answer it, Chair. So again, I would ask for specific details regarding the specialty from the inquiring councillor, please. Number 6, clarification regarding the death certificate.
Chair, I might just, sorry, Geraldine, interrupt. Just Councillor Warrington has raised his hand at this point. It might be in relation to that query. Sorry, Chair.
Yeah. No.
Okay, sorry, Victor, I didn't see you there.
You're okay. Geraldine, it wasn't me actually raised this query, but just one answer, one question. Obviously, we know that Altnagelvin is the kingpin of orthopaedic services within the Western Trust area, and unfortunately, I've had reason in the last couple of months to be attending quite regularly and have been up and down the A5 Altnagelvin quite a bit. I suppose one of I know there is a consultant or certainly a senior registrar comes down to Enniskillen maybe once a week, but on one of my journeys to Altnagelvin, I was in and out, I would have said, in 30 seconds. After traveling from Fermanagh up, I'm not complaining. I went up hand and heart with as I do to any checkup, but I can see where there is potential for people to be annoyed at having to travel up for such a something very, very simple that like that incident that I'm talking to you about, where I was in and out in 30 seconds. It was a nurse-led appointment that I ended up having, and it certainly would have been a lot easier for me and for a lot of other people if they could have jumped into their vehicle and went to either Fermanagh or to the SWA or Omagh to get it done. So something maybe put out there. Thank you.
Yeah, and I suppose I accept what you're saying, Councillor Warrington, and I suppose the only thing about orthopedics is it's split into quite a number of body parts, and it may not be the right person that might be in the clinic in Enniskillen versus somewhere else. Obviously, you said it was nurse-led, so look, I'm happy to again put it out there. Any specific issues, I'm very happy to look at. I'm sure Mark would be the same for orthopedics in terms of attendance at any clinic. The clinic in SWA, I believe, is a fracture clinic, so it's treating the patient and their very acute phase of their journey. Mark, you want to come in, do you?
I was just going to say, Geraldine, under the work stream and delivering value, we're actually looking at postcode in terms of allocation of outpatient clinic close to home. So it's a really important point in terms of maximizing capacity and also making sure that people come to their clinic appointment. So it's something that we're acutely aware of, and we're actually doing work on it. So happy, Geraldine, to provide an update. Clinics closer to home will obviously encourage people to utilize that clinic. So it's right in that space. So a really important point.
Okay, thank you. Are you content enough with that, Victor, or do you want me to do something more than that?
No, I'm not looking at any special treatment. It was just something I thought when the question came up that I'd like to highlight from my own personal experience, but certainly something I think that would benefit from maybe being looked into. Thank you.
Yeah. Okay. So point 6 then is around the death certification process in Southwest Acute Hospital. I suppose this has been included in the public reps brief since the last meeting, and it has been responded to. I suppose the only thing I can add is that this is a legal requirement for us. We must have the death certified by a medical practitioner who has seen and treated the deceased in the previous 28 days. We cannot step outside of that. And that has already, it does happen on occasion, and unfortunately it did happen a couple of times over the last number of months, but it does happen sometimes at Galvin Hospital as well. So it's a legal requirement, it's a coroner's requirement. There's no moving away from it on our part.
If I might just add, and Geraldine has rightly referenced the previous members' brief, the council also has separate correspondence into the trust on this issue, and I know there were some supplementary queries as part of it. So I think maybe Geraldine, or Chris might advise, I think we might be receiving a more detailed response to those additional queries, which will no doubt reference the comments that have already been made. So just for completeness for our members.
Thanks, Alison. Chris, are you?
Yes, it was just to say, Alison, I was just double checking, and yes, that detail, there was one query we had to check, which was actually directly in relation to the coroner. So that will be going back to you in a brief. So
that's okay.
Thank you.
Yeah.
Okay, so the next query was around the current daily rate for GPs and how difficult are they finding it to fill the slot. So that's something that I can't really answer. That's an SPPG directed question. We don't employ GPs at this stage in the trust, on my part anyway. The next point is around active recruitment. What active recruitment is ongoing for AHPs or allied health professionals, and are there plans to restructure the workforce? So what we will do is supply a briefing at the next council meeting, or we can provide it in the e-brief sooner if that's if you're happy enough with that, Chair. It just needs a bit of work, and we need to do that, and we're happy to do it, but we'll supply you with the brief and a format that you're happy with, if that's okay. And then there's a few queries around the surgeries. So Maura, I'm not sure if you're providing this, or I'm happy to read it out. Has there been a wholesale review of processes in these surgeries to improve efficiency and patient service? So just verbally, there's the Department of Health requested the Western Trust to take on the following APMS contracts in order to ensure the continued provision of general medical services to the patients in these practices. Trevor and Trillick practice 1st of July 22 to 31st of March 23. Racecourse medical practice 1st of June 2023 to 31st of March 23. And Brookborough and Temple GP practice from the 1st of September 23. Initially, in supporting the practice managers, the Trust oversees the GP rota for both practices. In doing so, has developed a positive working relationship with GP locums, ensuring the necessary cover is in place to provide GP services. And there is a more detailed brief that will be provided in the public reps e-brief going forward. Okay.
Okay.
That's That's full members' queries, Chair. Thank you.
Yeah, and let me see, I can't see anybody indicating, but let me double check. No, that's fine. And anything, those missing bits there, we're gonna get a little later on in time for the next meeting, maybe. So the next item is item 7. I'm not sure who we're going to for that.
Chair, I'll maybe just, it's really for noting, so the Health Subcommittee would be our appropriate reporting channel for the Strategic Development Group terms of reference and minutes. We are including an item tomorrow evening at Policy and Resources, Chair, just in terms of the Council's continued participation. So really just for information. And I know Mr. Guckian spoke to this item earlier. So really, maybe just a proposer and seconder to note, and then there'll be discussion, I'm sure, tomorrow evening.
That's great, Alison. So can we have a proposer, please? If you can, somebody come in. Errol, thank you. And somebody to second? Colette, thank you. And everybody's in agreement, yeah? Yeah, I'll take that as yes, because nobody said no. Okay. So we are now going on to item 8. And there's one piece of correspondence, Alison.
Yes, Chair, and again, I maybe deal with this. So this was something that was referred from the council meeting on the 7th of November, and it was referenced in a letter from the Permanent Secretary of the Department of Health to a new initiative, which was really around, so I'll give it its correct title, attract, recruit, retain scheme. And it was requested that we refer it to the subcommittee meeting. We have in the intervening period as well, Chair, made contact with the SPPG, who would be the appropriate authority to comment on the letter, but we haven't received any responses yet. We do also have an action from the council meeting just to follow up and to find some further detail. So again, I'm sure it's not something that's in the prerogative of trust colleagues. So if we get a response from SPPG, we will report that back in due course.
Okay, and nobody is indicating. So thanks, Alison. So the next item really is any relevant business, and nobody's contacted me to bring up any extra items. So you'll be glad to hear that that's the end of it, apart from the date of the next meeting. And just my own thoughts, and I know that we do have these meetings, but if we could plan at least, maybe not the February one, our next meeting is in February, and it could be very cold, and depending on whether it might not be suitable for traveling, but maybe if everybody can consider the following one after that, maybe that we could meet in person, either in Enniskillen or maybe in Omagh Chamber, if everybody was in agreement to that. Errol?
Yeah, thanks very much, Chair. I think that is a good idea. We don't do it often, but I think it's ideal to get the whole group together, maybe a couple of times a year at least. So if you're proposing, no, well, I'll propose because you're the chair, so I propose that happens.
Thank you. And can we have somebody to second, please? Colette. And everybody's in agreement. Nobody's opposing anyway. So is everybody representing the trust happy enough with that we meet once or twice? You know, if we have every other meeting or something in person,
Chair, can I? It's just sorry, Chair. Can I just make a minor point? We certainly can work on the logistics with trust colleagues. I suppose it's just to note the council already has a decision about subcommittees that we meet on a virtual basis, so we will just need to work that through our own internal processes. I'm not saying there'll be any difficulty, but it's just that we would maybe work on that basis. In the meantime, we could perhaps liaise with Chris and his team just to see the dates that might work best, because we have the full schedule agreed and the location. Thank you.
Brilliant.
Sorry, through the chair, thanks for that, Chief Executive. I'm aware of that situation, but I just think it's probably important that we do from time to time meet in person, as the chair has already said. Thank you.
Chair, I think we're happy enough if we can arrange the dates with Chris. I'm happy enough to Thank you.
That's great. And nobody has anything else to add? No? Okay, well, that's that. We look forward to getting some of the other information that's coming along after this, and we won't be meeting before Christmas, so it's a little bit early, but have a nice Christmas, everybody, and stay safe. And I don't plan any more storms, by the way.
Thank you.
Chair.
Thank you.
And
Okay.
thanks to the team.
Take care. Bye-bye.
Bye.
Bye.